I am Mateus Cunha. I am a clinical fellow here at Sunnybrook. I work among other sites in the lung group, and I'm here to talk about a little bit about artificial intelligence, and especially its emerging role as a predictive and prognostic biomarker tool here in the context of non-small cell lung cancer, applied also to immunotherapy. So there's always a quick introduction about lung cancer. I got some data from sites from Canada. So lung cancer in Canada for 2023 is projected to have 31,000 new cancer cases. And in 2023 also 20,600 cancer non-small lung cancer deaths. So it would be 24% of all cancer deaths would be due to lung cancer. And of those new cases, 85% is non-small cell lung cancer. As you can see below, that's data from Statistics Canada. It's from 2011 to 2015, but basically 50% of all cases were from metastatic non-small cell lung cancer, while about 40-something% would be earlier stages. And data from the Canadian Cancer Society for 5-year survival in non-small cell lung cancer from 2010 to 2015 shows us that, while about 60% of patients with stage 1 non-small cell lung cancer are alive 5 years later, were alive 5 years later in that analysis, it is survival is inversely correlated with staging, and stage 4 cancers would account for 3% of 5-year survival. Doing a quick math here, so basically 40% of deaths in 5 years due to non-small cell lung cancer would be like 40% for earlier stages 1 to 3, and advanced stage 4 would be about 60%. But mortality has been improving with immunotherapy. As I showed you, that data is from 2010 to 2015. And since 2015, we've been starting to use immunotherapy more consistently, especially after 2016, when pembrolizumab was approved for first line in patients with a PD-L1 more than 50%, and then atezo for second line. What we have as a best biomarker as of now for predicting success of immune checkpoint blockade is PD-L1. We do have some other biomarkers, but what we use the most is PD-L1. And while in adjuvant in the adjuvant setting, we had an approval for all PD-L1 status based on a progression-free survival analysis. In 2023, we had an interesting surprise in the publication by Dr. Enriqueta Philip that showed only a survival benefit for those patients who underwent adjuvant immunotherapy with who had PD-L1 expression of more at least 50%, while the other 1 to 49 and negative would be non-significant. So it was a 15.2 absolute 4-year overall survival benefit. And while we look at some some other data that we have, so looking at the Pacific trial, for example, we do see that there is a 9.5% absolute benefit to doing post-chemo radiation maintenance durvalumab in stage 3 cancers. But when you look at subgroup analysis, and that was their updated publication, we see that for patients with less than 25% PD-L1 expression, we do not see statistically significant benefit. Even if we just isolate 1 to 24% and take out the patients with negative PD-L1, we still don't have a positive benefit. Stratifying by the same standards, we do see that in no groups there is a non-significant increase in adverse events, especially for grades 3 to 4. For PD-L1 negative, we have an increase of 6.2%, an absolute increase of 6.2%, not relative, while for 1 to 24%, which also doesn't have statistically significant benefit as per the data for development, we have an increase in 12.2% of adverse events. So that's a very significant increase for a non-certain benefit. Of course, these analyses aren't, the studies wouldn't be actually adequately powered to see those analyses through, but we have to take what we have, right? Looking at the new adjuvant scenario, we do have a little bit, but we also have a scenario which with this distribution of efficacy per PD-L1, where only patients with more than 50% PD-L1 expression had a benefit, a statistically significant benefit, and this is for Checkmate 816. They also did analysis for TMB, and TMB was also a not a predictive biomarker for the treatment. And while you look at perioperative pembrolizumab, for some reason, only patients with negative PD-L1 had non-significant benefit, didn't have a significant benefit, while 149 and above 50% did experience a significant benefit in those subgroups. Even when we look at first-line immunotherapy, that's even more puzzling. For first line, if we have when you have the association of nivolumab, ipilimumab, and chemotherapy, all subgroups had a statistically significant benefit, even with some degree of increased adverse events, but they also had better responses. While looking at the data for pembrolizumab with squamous cell carcinoma histology, we don't see a clear additive effect or a positively correlated effect of survival versus PD-L1 expression. As you can see, in the right side of the board, we see PD-L1 less than 1% is hazard ratio of 0.68, non-significant, and then we get basically the same hazard ratio for PD-L1 more at least 50%, although statistically significantly. On the other hand, for non-squamous histologies, we do have somewhat increasing effect of benefit. So that's also puzzling. We see that PD-L1 might be predictor for some people, for some other histologies, not for other settings, it's not predictive at all. So we have no idea where to apply that, right? So although immunotherapy has an increasing role in the treatment of early non-small cell lung cancer and non-small cell lung cancer in general, PD-L1 is the best we have, but it is imperfect at best. So could be golden coins, but for now we can see that that's chocolate coins. And well, the way some of what we might have in lacking of biomarkers might be how we classify tumors. So we mainly use pathology, radiology, and molecular biology to look at those tumors. And while molecular biology on its own might usually not be very helpful, when you get all of those VUSs, you don't know what to do about them, or wild type EGFR amplifications that we don't know really what to do about. Radiology and pathology are mostly subjective descriptions of the tumor. And while both radiologists and pathologists might be very mad at me, give me a second, I'll try to make a point. We do also another hindrance is as we usually look at those in somewhat isolated. We do make some correlations, but as we can see, they're usually superficial. And for you see mutations versus PD-L1 to see what you're going to treat with, but usually when you have a mutation that trumps anything else for histology, or if you have high PD-L1, you already know what you're going to treat, chemo, immunotherapy, or higher PD-L1, just immunotherapy maybe. So some things trump others, and we just don't tend to consider it in a more simplistic way. And other caveats are those for tumor classification, taking a look at that part of the subjective thing. For radiology, for example, we do see that the files, the DICOM files, they're the files in which the whole CT scan or MRI are stored. Each pixel for that image, or voxel, if you think about three-dimensional image, has about 12 to 16 bits. That means it's from anywhere from 4,096 to 65,536 different shades of gray that can be in each pixel of that image, while the monitors or the displays are 10 or 8 to 10 bits per pixel. Radiology displays are usually 10 bits per pixel. Normal ones that we use on a daily basis 8, so it's anywhere from 256 to 1,024 shades of gray per window or level. So remember that we do window those images according to where or what we want to see. And the human eye, fully adapted to the environment without any hindrances, can see basically 1,000 shades of gray depending on the luminance. When you look at the luminance of the LCD screen, it's about 720. I know it's a lot of numbers, but like simplifying, if you have a 16-bit CT scanner, so the best details possible, with a 10-bit monitor, you have 65,000 shades of gray for 720 different shades of gray per window. So you can only get 1.1% of the information. Physically, you can only get 1.1% of the information available in the image. While if you have a 12-bit CT scanner in the lower end of what we have available with an 8-bit monitor, you only have 266 shades of gray for all the 4,096. So per window, you only have 6.3% of the available information. Furthermore, when you look at Hose light image files, so that's basically the DICOM files for digital pathology, they have a 24-bit red, green, blue color, so 8-bit for each channel. That is 16 million different colors, basically. And commercial displays usually match this. But as you can see, different monitors, due to lack of standardization, can show different colors and different luminances for the same settings. Differences in the technique of how the slide was prepared and how it was scanned and how it was stained will also cause some variation in information that we can receive, and even ourselves can cause some variation. You can see that different seeing patterns here will imply in different color perceptions, or even not only how our brain receives information, but how it processes it. So we can see that misleading context cues, like here, you can see that the orange circles were the same size all along, and tiles A and B, although they look different, they were the same color, can also influence how we read each image, be that in pathology, be that in radiology. So how can we try and reduce the influence of these caveats? How can we give a more objective classification and see more patterns? Well, one of the things that we usually do for image interpretation is prefabricated features. So we can do that either with CT scans or with Hose light imaging, and segment the tumor either into 3D for the CT scan or 2D for nuclei segmentation, and analyze for things that we have planned in advance. For example, roundness or sphericity of the segmented image, the margin, if they're regular or not, if they're spiky or not, their perimeter, surface area, volume. We can organize the shades of gray or even the different colors and histograms and interpret those. So see max and minimal values, variance, skewness, kurtosis off that histogram, or either see the texture or how random these colors are distributed, or do some filters. So that'll go about a little bit of those later on. There's also deep learning. So other thing that we can do is let the computer figure out those features for itself. So if we try and make a computer, a neural network to recognize different emotions in a face, you'd give a picture of a face for it to interpret. It would break down the face in different features. For example, the first layer would be to recognize very simple patterns like lines and circles and different contrasts between bright and dark parts. And while combining those, they would become roughly different features of a face. For example, an eyeball or surprised eyebrows or anything else. And composing those things together, they'll become faces or patterns of faces that you could use to compare your new data to what you've trained before. So you can see how roughly, and this is a very rough interpretation, of course, of how the first layer of neural networks would see an image, for example, to search for vertical lines in the first image, or horizontal lines in the second, or different sharpened edges, so different any different edge in a picture or difference in colors. In this case, shades of gray, of course. So, and this is one of those kinds of filters you can use for pre-specified features also. And how can we use this to realistically try and implement this in a prognostic or predictive score for non-small cell lung cancer? Well, for example, a team of researchers, if I'm not mistaken, this was from China. They took 4 different online publicly available cohorts, so basically 2,000 different patients with advanced non-small cell lung cancer. They took those whole slide images, they segmented into small pieces of grid, classified those with certified pathologists and a part of those grids, because we impossible 2,000 patients to do everything. And then they ran a deep learning, they trained a deep learning neural network to try and recognize those features and characterize those in either inflamed, immune excluded, or immune desert. And oh, sorry. And after analyzing the slides, but with 518 patients who received monotherapy immunotherapy, they saw that the computer was actually very good in classifying between inflamed, immune excluded, and immune desert, even separating with consistent patterns of different immune cells that would infiltrate those tumors. When they separated for PD-L1 TPS, for example, they saw that the patient, it was consistent with the number of immune inflamed patients would be consistent with patients who had a PD-L1 TPS of more than 50%, and 1 to 49, 0, like 0% being the lowest percentage of immune inflamed. And they also saw that patients who had positive TPS, who had an inflamed phenotype, would have a better response and better progression-free survival compared to those with non-inflamed phenotypes. So that would be a very interesting predictive tool to better stratify patients who more than just using the TPS. For transcriptomics, looking at their transcriptome analysis, some researchers also did an analysis with 30 patients. They wanted to know prognosis of patients with ground glass opacity, sub-centimeter ground glass opacities in the high resolution CT scan. And they saw that some of the patients in their institution underwent surgical resection, and they had confirmed lung adenocarcinoma. So they took those patients, ran a transcriptome analysis, and saw the differential expression of the tumor versus the stroma and normal tissue in those patients. They performed in a machine learning analysis called non-negative matrix factorization. So they take a big matrix, transform it into 2 different smaller matrices to try and see if there's a better subgroup division. And they saw 2 different subgroups. After seeing, after reducing the dimensionality of those matrices and seeing which were the genes, the differentially expressed genes that had a better correlation with some of the groups, they actually discovered 15 different genes that were either up or down regulated in each group. And they validated that in the TCGA lung adenocarcinoma dataset, another publicly available dataset with whole transcriptome analysis and whole image slides, and also, I'm sorry, and data, but I have some radiology, some slides data. They saw that different clusters had significantly better survival. Of course, they would, after 9 years, have a collapse in survival differences, but for 9 years, that's a very good difference. So that being a prognostic tool for evaluation of sub-centimeter ground glass opacities in high-resolution CT scans. For radiomics, for example, so using machine learning for radiology exams, this group from Ohio in the United States took patients who would receive monotherapy immunotherapy, and they do baseline radiomics. So they did pre-specified features of radiomics, both before cycle 1 and after cycle 2 of immunotherapy administration. And they used the delta radiomics, or the difference of those radiomics, to try and predict survival of those patients. They also did try to do a radiopathomic association. I'm not sure if I included that, but I can comment a little bit. And what they could see is that using both, they had different patterns for patients who were responder, here as in B and D, versus non-responders, this is A and C. So you can see there are different patterns here, and both, and a different pattern of intratumoral and peritumoral radiomics. And that, and while doing a stratification by different data that would possibly affect survival, they saw that the most significant ones was tumor shrinkage after 2 cycles, which is kind of obvious, but also best radiomic features, and the whole score for radiomics were very significant for that survival. That was for 60 patients, if I'm not mistaken. Yeah, and they also did a correlation with pathomics, and saw that these scores were very well correlated with tumor infiltrating lymphocytes. So they could detect those in a CT scan, which is very interesting too. So I was talking about interpreting things in isolation, and sometimes we need to look at things and try and correlate them radiologically, clinically, or pathologically. We hear about that from our colleagues a lot, where we sometimes don't do a very good job of doing. Another study from the people from Ohio was with 68 patients with early non-small cell lung cancer that underwent resection. This was a study from 2019, if I'm not mistaken. So not a lot of no neoadjuvant or no neoadjuvant immunotherapy. And these patients, these slides, they were analyzed for both pathomics, basically a cell architecture and tumor infiltration of normal tissue, and so they're reading architecture basically, and intratumoral and peritumoral radiomics. And what they found is that although their scores in isolation wouldn't have a very good predictive value, their scores together, so they used both scores and ran a machine learning model to try and predict, based on often that data, who would be a good survival, who would have a better overall survival from that. Was way better predictive, with a hazard ratio of 3.4, different from low risk to high risk. So also a very good prognostic score that could be validated somewhere else. Although we do use a lot of data and do use a lot of computing power for artificial intelligence, it's not perfect. It's we have several possible sources of error. Sometimes from the data itself. Some patients don't have a lot of data. Some groups of patients are very small, so we don't have enough data to interpret. Or sometimes the data is just not very well entered in the database. So sometimes you have missing data, human error, misclassifications. But we can also have some different things. For example, information leak or occult correlations. There was a very interesting analysis that was done when a group of researchers was trying to do a detector of husky versus wolf with only images. And they have a very, very good classifications. They rarely got those wrong. But when they started analyzing the ones that were wrong, they discovered that they weren't building a husky versus wolf detector. What they were seeing was a snow detector, because anywhere the machine would detect snow, they would classify it as a wolf. Very funny, very interesting, this example, because it was kind of silly, but the same thing can happen sometimes for diseases with different prognoses in different, for example, biologically different patients. So, for example, there is a study. There's evidence about, for example, machine learning models being able to discern women from men in cranial X-rays or CT scans, for example, or even the recognition of the patient's race from a chest CT scan or chest X-ray. So I'm certainly not able to do that. So that's very interesting. It's definitely that sometimes you can even leak this kind of information from that. So that's one of the hot topics in machine learning now. Also bias. So how patients actually receive treatment or receive different things when entered that in the database might influence how the machine learning model will predict those patients to fare. Sometimes patients who have lower socioeconomic status will receive lower cost interventions. So a machine learning model, for example, in the United States, one of the models that health security enterprises use to classify projected patient costs actually attributed lower risk, lower cost interventions for patients who were of a lower socioeconomic status, for example. So there are several different impacts that can be derived if those machine learning models start being used in large scales, for example, especially for policy making and, of course, for informed clinical decision making. So what I take away from here and what is some very interesting things for me was that artificial intelligence is an emerging field of research, and the integrated use of objective tools to evaluate non-small cell lung cancer may lead to a way more personalized treatment pattern than what we see today. Of course, that's for the next chapters of the series, but we'll see. And last but not least, we need to pay attention and see that AI models can have unexpected influences in the care of different patients, especially when discover and along the line when using it or testing it, different information leaks and biases that we might have put there unintentionally. So I think that's it. Is there any questions? And you can.
Thank you so much. Does anyone have any questions? Give you a minute. Maybe while people are thinking of questions, can you give us, because I know you have a lot of kind of previous experience in this type of work. Where do you see this? Like, is there a certain group of patients or stage of patients? Like, where do you see this being the most useful as a starting point to apply these types of technologies?
Yeah, Well, I did. There's a very important problem in the medical community now that can't. I didn't comment on that, but for example, doing a lot of paperwork and administrative tasks. Sometimes it can be uh, delegated to AI for the most part, and then we just see if everything's okay. Would save a lot of time and would impact a lot on provider overburden, especially out of office times. But thinking about lung cancer, I think maybe thinking of treatment escalation or de-escalation according to uh, protective response patterns to immunotherapy, for example, would be very important. Immunotherapy itself is a very, very expensive treatment. I come from Brazil, and there it's about if you take basically 10 years of minimum wage, you can treat one patient for maintenance durvalumab. So that's a lot. Being able to discern who's the patient who would actually benefit from it and not derive only adverse effects would be a very useful tool, even for families to consider very important financial decisions they might have to take for treatment. So that's one of the very important things. Doing prognostic markers is also very important, but also very important. So doing predictive and then validating for prognostic if possible would be also very good.
So
Thank
thank you
you.
for that very interesting talk. I'm wondering if there anything that AI can do, because your PDL1 score really depends on how good your biopsy is and what the sampling effectiveness is. So what can AI add to overcome the problem of tumor heterogeneity? Is there some radionomic feature that might correlate with PDL1? Is there anything else we can integrate AI to help improve the accuracy?
Yeah, this is a very, very good question, especially because we have recent data that shows that when the metastatic disease genetic profile is actually different from the primary profile. The primary continues evolving, the branch that actually got to metastasize sometimes is different. So the site that we do the biopsy is also very important. But there is evidence for a better yield and better results for patients with immunotherapy using radiomics to try and guide more active regions of the tumor or more important regions of the tumor. So there was a study that they did mark where the biopsy was performed in a tumor. I don't remember if that was localized or metastatic. I can search that and send it to you. But they marked where it was made, and they tracked how the patient fared according to treatment. And since they did have not very good, but there was some correlation there between the radiomics of each region of the tumor, where they performed the biopsy, and how the patient fared with treatment with, I think, if I'm not mistaken, it was immunotherapy, but it might be targeted treatment. I don't remember very well, but there is some evidence about that. So that could be something.
Thank you.
Patrick, your hand is up.
Yeah, thanks for the talk. So I'm one of the radiation oncologists here, and we actually Anastasia is here too from radiology. We did a project a few years ago looking at radiomics analysis for early stage lung cancer treated with SBRT, and yeah, we found some relationships and everything. But my question really is, let's just stick with radiomics. I don't know anything about pathomics, okay, but radiomics, okay. It seems to me there are so many, when you look at these projects, there are so many factors. It's like a black box on exactly what they're looking at. We don't really know sometimes. Maybe a radiologist knows, but I don't. When I read these papers, I don't know what these mean, these factors, even though they seem to correlate with outcome. My question really is a broader one. Say more and more studies come out, and we find these things that correlate with, are predictive for outcome. And as you say, the hope is that you can use this information to help with your decision making upfront, right? In terms of how to best treat this patient. But with drugs, you need Health Canada approval. Even with new devices, you need approval from a government agency to say you can start using this clinically. Or for radiomics, let's say, it's such a black box. How do you think it's the same criteria applies in terms of what makes something then good enough that it will be approved for clinical use? You see what I'm saying? Devices need clinical use approval, drugs need government approval. So where do you, maybe I don't know if it's an unfair question, but where do you see this going in terms of when will something like this be actually allowed to be used clinically, and what data do we need to achieve that?
Okay, that's a very good question, and that's one of the questions is always brought up. I'll address it. I'll try to address it in parts. So, first of all, black box. I don't see this as an impeding factor for use. Can you tell me the exact mechanism of action of Tylenol? We don't really know exactly how it acts, and still we use it a lot. So I don't see that being a problem for using Tylenol, although Tylenol, people can get overdoses and die because they took a lot. Well, the second part would be thinking about data. So for a drug approval for us to use, or even for devices, we need to have a large amount of people who went using the equipoise principle. So we have the question that people might benefit or might not benefit from the machine learning algorithm, let's say for your SBRT algorithm for early non-small cell lung cancer. So patients can undergo either, we can use the algorithm to try and differentiate patients who fare to, first of all, retrospectively see patients who benefit from, who classify patients retrospectively and see how they fared. If they benefit from this therapy, who benefited from this therapy, or who had a classification that they would. So patients who had received SBRT, we classify it with the model and see if they had, for example, the model predicted that they had a higher chance of benefiting from SBRT. Great, we need now have a possibly predictive model. The second step would be to try and validate that with a different cohort from a different institution. So getting another cohort from this different institution was performed by different professionals from different machines, and to see if our model still performs well. It will probably have a drop in that performance, and we can use that data to improve the model and see how it goes, and try a third or any online bank if there is. The next step would be try and validate prospectively. So seeing patients who are fit for doing SBRT, early lung cancer, classify them, don't look at it, see how it goes, and then see if it really was a good model for the same thing. Prospectively validated is a gold standard for a machine learning model, but it's not enough for it to be implemented in the market. It has to be friendly for physicians. Most machine learning models are not friendly for physicians. They're hideous to look at. Sometimes you just type something in a command prompt and it will analyze things and spit a number out. Numbers really, really scare physicians. So the last part would be trying to integrate that to make a very good product, and then try to get it validated or get it registered for something. Of course, for example, one tool that was developed for with machine learning, and we use it routinely because it just became the same thing as a laboratory exam, is Myriad for ovarian cancer. We're seeing homologous recombination deficiency in ovarian cancer. It is a genetic pattern. It's a gene analysis pattern, but it was developed with several different models of machine learning. They run the results in an algorithm, and they give you a result of for the homologous recombination. They give you a score, but they give it in the format that we can understand. So it's a number score that's just like a lab exam. So sometimes if you hide the machine learning behind curtains and say it's a lab exam or it's a radiology exam, just like those algorithms that look in chest X-rays or to look at CT scans to detect thromboembolism, There are several private institutions, even in Brazil, that use that. So they prioritize pulmonary thromboembolism for the radiologist to see, or CT scans with signs of bleeding. Machine learning already does that. It is already employed to prioritize those exams and help physicians actually track those things. And still, it's hidden behind curtains. So that's another way for you to implement those things. For me, the biggest question is if the algorithm makes a mistake and there's a bleeding, it did not find, and it did not treat the patient's stroke in time. They died. Whose fault is it? This is an ethics question that's still running around. We still don't know. I don't know if I answered your question, but like sometimes it's how it goes.
Well, I think that what I took from you is that I think you say the gold standard really for maybe to adopt and maybe have government approval of such an approach would be a prospective trial, a prospective analysis, ideally multi-center. So it's broadly shown that it can be used. The algorithm is reliable, and it can be reliably, you get the same results. But do you think you need to randomize? Do you need to randomize anything, or is it even as a non-randomized such an approach would be good enough?
To be honest, I do think that inserting those things in doing the same thing as we did for validation of other biomarkers like PD-L1 and stick that in clinical trials and start with those analyses as a good thing. Randomization is usually one great thing to do because it will reduce bias and criticism about if you do not include randomization, if you do a prospective trial, especially if your algorithm will guide clinical decision making. If you are going to do only the patients who are likely to receive SBRT will undergo SBRT, the rest will do resection, I think randomization would be best. And then you measure those things, so you take it at random, right? Although it would also help patients to not run away at the first sight of doing the machine learning thing.
Okay, thank you. Great talk.
Can I ask a question too?
Of course, go ahead.
I enjoyed your talk, Mateus. Thanks for doing it. Did you mention, I thought you briefly mentioned something about a CT scan can identify infiltrating T lymphocytes?
Yeah, it's not that it identifies TILs. The thing is, what they did for the correlation is that they built this radiomic score, and well, I cannot in my head separate tumor architecture from cell infiltration.
Right.
So probably what they got, their data show that the pattern of better response to immunotherapy was also a pattern histologically that had more TILs. And we do see emerging data about TILs and immunotherapy effectiveness for non-small cell lung cancer. So probably what they did was detect radio phenotype that is associated with higher tumor-infiltrating lymphocyte. I don't think they detected TILs. I think they detected.
Like they correlated in some way. Could you send me that paper, or I'll get it from you some other time?
Of course.
Thanks.
If there are no other questions, then thank you so much, Mateus, for giving us this awesome talk. We look forward to hearing more about your work, and hopefully we have sparked some interest in the group for AI, and yeah, we're happy to have you here. So thank you for your great talk.
Thank you very much. Thanks, guys.
Thank you.
All right. Bye, everyone.